enema tubing. So before you put that tip in, what's going to happen is the contrast will be filled up here, okay? And the rest of the line will have air. What you want to do is you want to fill up the tube with contrast as close to the tip as possible. We don't want this air full of line, because what's going to happen is the moment that you put that tip in and then they tell you to open up, air is going to get pushed in there before the contrast goes in. So we want to push the air out and get the contrast till about here. So how do you do that? Well, it's just simple. It's just gravity. Okay? See how that goes up and down? See that right there? It's just all gravity. So I'm just going to put it until, see, and it's always at the level of the contrast in the bag, right? See how it always stays at the same level? So I'm just going to move it until the fluid is near the tip, and then I clamp. It's not really a close tight system. Okay? Do you guys understand that? Bless you. So get rid of the air, push the air out before you put the tip in. All right, so summary of enema tip insertion procedure. So you're going to describe the tip insertion procedure to the patient and answer any questions that they may have. Number 2, place the patient in the Sims position. Patient should lie on their left side with right leg flexed at the knee and hip, that's your Sims. Shake enema bag once before to ensure proper mixing of the barium suspension, and allow the barium to flow through the tubing and from the tip to remove any air in the system. Wearing gloves, coat the enema tip. So one hand I'm going to have my enema, and one hand I'm going to have a towel, a paper towel full of KY jelly, and I'm just going to lather it up. Okay? So wearing gloves, coat enema tip well with water-soluble lubricant. Wrap proximal aspect of the enema in paper towel. That's what we're talking about, lube it up. And then on expiration, direct enema tip towards the umbilicus. Okay, so here's the rear end. The tip is going to go in this direction, okay, towards the umbilicus. I got a picture to show you guys. Towards the umbilicus, approximately 1 to 1.5 inches. And then after initial insertion, you're going to change the angle going upwards and to the front. Okay? Slightly superiorly and slightly anteriorly. The total insertion should not exceed 3 to 4 inches. Okay? This is the important part, is do not force the tip. If you feel any type of resistance, don't do that. You're going to tear something. Okay? So if you feel any resistance, get the doctor. Okay? She shouldn't have to force it in. It should just go in nice and smooth. Okay? Tape the tubing in place to prevent slippage. Do not inflate retention tip unless directed by the radiologist, and ensure that IV pull, again, another importance here, is the bag is no more than 24 inches, not more than 24 inches above the table. Okay? Because the contrast is going to flow by gravity. The higher the pull, the stronger the force, and it's just going to shoot right through the intestine, may cause damage. Okay, so 24 inches is a good height, which is probably, for most of us, it's going to be eye level. Okay, it's a good height. And then the doctor also, here's another thing that the doctor might tell you to do, is if the contrast isn't flowing properly due to some kind of complications, he may have you raise and lower the IV pole to control the flow. Okay, so that's another thing that you guys will be doing. Okay? Ensure the tubing stopcock is in closed position and that no barium flows into the patient until they tell you to. So again, be ready to follow the commands of the radiologist. Any questions? Yes?
Dumb question, but
No.
Is there like a marking on that to tell you like don't push in any further than this or stop here?
No, not at all. So the key here is you don't want to go in too much.
Yeah.
Okay? Now what's going to happen is the key is, again, don't go in too much. So based on what we said there, it's just gonna be some slight.
Squirted?
I'm sorry, I didn't mean to do that. And these are not good clamps because they can easily break. I've broken a bunch of these. I know it's still going.
That's okay.
I want to do this. I want to do this. Okay. So let's just say this is the rectum, okay? So again, the key is not, you don't want to go in too far. So even if you get in like this, when you inflate the balloon, it's going to take it in the rest of the way.
Oh, it will.
Yeah, it's going to take it in. So let's just say like this. It's going to, the balloon is, as it inflates, it's going to pull it in the rest of the way as you inflate the balloon.
Okay.
Does that make sense?
Yeah.
So it's kind of like, yeah.
Okay.
So it'll push it in slightly forward. And then after you inflate the balloon and clamp it, then you're just going to do your test tug to make sure it's secure.
Okay.
All right, so again, slightly in towards the umbilicus where the belly button is, and then you're going to change your angulation to go superiorly and slightly anterior. All right? All right, any questions?
Bless you.
Okay. So, 3 types of lower GI studies. Again, one is single contrast, bless you, double contrast, and also the defocogram. Defecography. Okay, it's an evacuative protography. Single contrast barium enema versus double contrast barium enema. In single contrast barium enema, there again it's just barium. There is no air. Again, a majority of what physicians will do is a double contrast, but there will be times where a doctor will order a single contrast study. So a single contrast study is good for identifying certain types of lesions and neoplasms. Okay, only certain types that can't be seen in a double contrast study. Yes.
We set up for one. It was for therapeutic because they.
Was it barium or gastrographin?
Gastrographin.
Yes, gastrographin. Okay, so here's the other thing about gastrographin enema. Okay, so as we said, when you're doing any when you're doing a barium enema study, you have to prep the patient properly. When you're doing a gastrographin, that's an iodine enema, patient is usually not prepped. So their bowels don't have to be clean. So as we had said earlier, because a couple of you guys have done this already or seen it, is a gastrographin enema where they're doing the enema for therapeutic reasons, and that's to clean out, because iodine is a cathartic. Okay, so not only it increases the contraction of the bowels, but it also loosens up the stool, and it just comes right out. Okay. You know what I do when a gastrographin enema comes up?
Jam?
Give it to
I
someone
take a
else.
break.
Get lost.
I take a break. A long break. No. All right. So single contrast study, that's barium, done for certain types of studies looking for different lesions and neoplasms. But for the most part, it's done double contrast with barium and air. Now with double contrast studies, there are, again, 2 different schools of thoughts. One is the 2-stage way, and the other one is the 1-stage way of performing a double contrast study. In the 2-stage double contrast study, they're going to have you turn on the barium, and they're only going to fill up the left side of the colon. Okay? And then what the doctor is going to do is So barium fills up the left side. Air is instilled to push the barium to the right side. Okay. So air, I'm going to use air to force the rest of the barium to go through the right side. And then the bag is lowered. Okay. Simply, I'm just dropping the bag on the ground, literally dropping it on the ground. Okay, because remember gravity. So when I chop the bag on the ground and open up the clamp, contrast from the intestine is going to drain out of the tube and into the bag. Okay? More air is instilled, and for neoplasms and polyps, especially those projecting into the lumen or opening of the bowel, this two-stage is what it's good for. This is not as common, but it is done. The most common way of doing it is just the one stage. The one stage is barium and air is instilled at the same time. Here, one, it's barium, okay? Air, drop the bag, fill with more air, okay? But they're simply, all they're doing there is they're lining up the mucosa with a thin layer of barium in the intestinal walls. Here, the barium stays constant, it's full in the bowels, and we're going to mix that up with air. Okay, so barium and air is instilled. That's a single procedure. It's less time, okay, better for the patient, and also less radiation when doing it this way. Okay, any questions? All right, then we have here the defecography study. It's a special type of procedure. It's a functional study of the anus and the rectum during the evacuation and rest phases of defecation. Clinical indications. Why do we do this? Rectoceles, rectal intussusceptions, and prolapse rectums, and I gave you guys a definition down here. So rectocele is a bulging of the rectal wall into the vagina. A fistula may also be formed. So we're looking for a communication between the vagina and the rectum. Rectal intussusception is a portion of the colon that slides into the rectum, and then prolapse is the lining of the rectum falls through the anal canal. So one is going up, the other one is going the other way. Going up, intussusception, going down on the prolapse. Okay. Now, I think there's a picture of this on the next slide over here, but there is a line showing the relationship between the rectum and the anus. Okay, so we've got a line over there. And what the doctor is going to do is they look at any type of movement and they study the angulation. So if there's any type of gross variations of changes in angles, it's usually an indication of some kind of pathologic process that's going on. All right. So they do it during relaxation, and they also do it in strain during evacuation. So relaxation and evacuation. And I found a typo on that when I was going through the slides. Anyways, I'll show you where that typo is here in just a moment. Basically just a man-made commode. Okay, it's handcrafted. Does that word get used too much? Handcrafted? Yeah. Handcrafted donuts, handcrafted ice cream, handcrafted cookies.
It's more personal.
Why didn't you just say homemade? Anyways, this is homemade. It's a homemade commode, okay, collecting receptacle. This study is, so you have the patient sit on the commode. They're injected. It's not like this contrast, guys. We're talking about like caulking thick type of contrast, and they use this mechanism to push the contrast into the rectum. Because it has to be thick. It can't be soft where the barium is going to leak out. Does that make sense? So it has to be a little bit thick. And then done in a lateral position. And again, they do the study, watching them. This is where the mistake was. So I think it's a stress or strain. It should be changed to rest. So they are comparing it between rest and evacuation. Between rest and evacuation, they're evaluating this anal recto angle. Who's done this or seen this? I think they do it at Kaiser Anaheim.
At Chelsea's hospital.
Yeah, they do it at Kaiser Anaheim. Because there's one doctor here in Southern California that specializes in this.
Yes.
Yeah, in Southern California. Yeah. Okay. If the rectum isn't the route, this is another way of doing it for someone who's had surgery in their large intestine, their bowels. So post-surgically, you're going to have an opening. Okay, post-surgically, where they put the colostomy bag. So what we're going to do is we're going to remove the colostomy bag and place it with a little square that has a port in there that will allow us to insert the enema tip into that little port, that little opening. That's already been created surgically. So all we're doing there is we're just putting another padding over it to allow for easy insertion of the enema tip into the ost, the colostomy. Okay, so summary of safety concerns, review chart, never force enema tip. The height of the enema bag should not be more than 24 inches above the table. Check for water temperature, not too cold, not too hot. And one of the things that we do, when you're doing your overhead shots, you're still doing it with the tip inside the patient. So the doctor comes in, he or she will do his fluoroscopic procedure. Again, patients all different directions, and now we're talking about maybe 7 or 10 minutes into the procedure. Now it's your turn to take your pictures, okay? Again, now you're by yourself. In getting those images, make sure that the patient doesn't get tangled. One of the images that you're going to do at the very end is known as a post-evac. A post-evac is simply that. We're going to lower the bag, bring any excess contrast from their bowels, and remember that trash can we were talking about? So the bag is going to sit in the trash can. I'm going to open up the clamp and let everything drain out. Okay? Then what I'm going to do is I'm going to remove the tip. But before I remove the tip, what am I going to do?
Deflate.
Deflate.
Oh.
Yeah, deflate. One of the biggest mistakes that you'll see techs do is they're removing the tip and like, why can't I get it out? Well, deflate, okay? So deflate, now you're gonna have your towel ready, you're gonna cover up their bum, take the tip out, and because the bag is already in a trash can, you're just gonna dump the rest of it in the bag. You guys with me?
Mm-hmm.
Okay, you're gonna clean up their bum, have them sit up, go to the restroom. Now, as they're making their way from the table to the restroom, there may be some drippage. Okay, keep an eye on them because you don't want them slipping on it, or you don't want to be slipping on it, and now you've got some problems. Okay, so escort them to the bathroom, watch them very, very carefully. Okay, have them sit on the commode. You may have to assist them in sitting down on the commode. And then you'll say, if you need me, I say, you go ahead, go to the restroom. I'll be right outside the door if you need me. Okay? Now what I like to do is I don't completely close the door. I leave it slightly open so I can hear and see, if they need assistance. But it's just a crack open. Okay? And now when you let them in the bathroom, it sounds like a war zone in there. Because you pumped them up with so much air. Yeah, it's just a lot of sounds going on. So first couple of times, you're kind of like, but then, you do this so many times, then you're used to it. And
There it is.
It's just natural after that, okay? And so as they're in there evacuating, I'm cleaning up the room. So now I'm doing my little housework. So they'll be in there about maybe 5 minutes and then they'll come out. Same thing, when they come out, make sure they're not trailing, get them on the table, and then you do your one film, that's your post-evac. So this is what it means, escorting the patient to the restroom, okay? Making sure that they're not, they're not having any accidents, okay? All sense of accidents, okay? Making sure that doesn't happen, okay? All right, you guys can look through that on your own. Okay, so barium enema procedure. You guys ready?
Let's do it.
All right. These are all the views that you're going to do after the fluoroscopic procedure. 1, 2, 3, 4, 5, 6, 7. 7 shots, and you got to do it very quickly. Very quickly, no mistakes. Okay? Because again, these shots here, they're still doing it with their large intestine full of air and full of barium. Naturally, they're going to want to push out. So we're trying to prevent them from pushing out and having an accident on the table. So you want to get through these images as quickly as possible. Okay? So pay close attention to your protocol in your hospital. Do they want an AP or do they want a PA or do they want both? Okay? In positioning your patient, it has to be smooth and in order. You guys know what I mean by smooth and in order?
One direction.
Yeah. So you're moving them. You take a shot. You take a shot. 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 You're not doing this shot, 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 shot. You want to do it in some kind of sequential order, so it's just one uniform movement from one side to the other. Okay. So this is going to be possibly your first shot is a prone KUB, lower GI. So it's right at the crest. We all know how to do KUBs now, right? Whether it's prone or AP, mid-sagittal plane at the crest. Another thing that I didn't mention before, but Miss said she mentioned it to you guys, and that's why I didn't bring it up again, is that when you guys are doing fluoroscopic studies, barium studies, you guys know you're supposed to up the KV, right? She said she told you guys. No? Oh, okay. So let me rewind here a little bit. When you're doing fluoroscopic overheads, you're not doing them in your regular 70 kV, which is your abdominal technique. You're going to use higher kVs. Why?
Because it's contrast.
Because of the barium. Yeah. So you need higher kVs to penetrate the contrast. So especially like this, we're not doing this at 70, 80 kV. We're probably doing this at about 110, 120 kV. Yeah. Okay? So that's your PA. So the entire large intestine, again, I don't know why they do this, but they're showing you an abdominal image, single contrast. We don't do a lot of single contrast, it's mostly double. And that's why I cut and paste this here as your reference. Okay? So the entire large intestine should be demonstrated, and in an PA or AP, if it's double contrast, again, be aware, be familiar where the contrast and air sits or rises in those different positions. Okay? But the entire bowel should show, you're doing this at about 40 inches. What are the breathing instructions? It's just plain and simple, hold your breath. Don't breathe. Because we're trying to go through this, don't say take a deep breath in, blow it out, take a deep breath in. It's just as soon as you position them, hold your breath. Click. Okay? Okay, from the PA, now we're going to do an RAO. An RAO is a 35 to 45 degree rotation. Okay? Less rotation if you're smaller, greater rotation if you're higher. It says 35 to 45, but what you will see out there in the hospital is everybody does their obliques in 45. It doesn't matter what their body habitus is. It's 45. But what I want you guys to know is this, 30 to 45 for an RAO. Okay? Central raise at the iliac crest. And slightly on the upside, which is the left side, from the mid-sagittal plane or the spine. Okay? Iliac crest, and then slightly above on the upside of the left side of the spine, mid-sagittal plane. Okay? This is, again, one of the biggest mistakes that I've seen out in the field, is when you're dealing with a large patient. Okay? This was an actual scan that was done on an obese patient. As you can see, even when you're large, your insides stay in the same place. And one of the biggest mistakes that I've seen is when you are doing a lateral or some kind of oblique position. They're not centering here where the internal organs are. They're centering where their belly is sticking out. Okay? So you still want to stay within the midline, the actual true midline of the patient. Okay, so RAO, and I put down here, it's the same criteria as an LPO. The right colic flexure, ascending, and sigmoid colon are going to be open. The entire large intestine should be demonstrated, but again, that's based on body habitus. So hopefully we can get the entire large intestine in there. Now, if the doctor is focusing on the flexures, you want to center just slightly higher. Okay? Slightly higher on your KUB. If we're looking at the rectal sigmoid area, then you want to center lower from your regular KUB. But again, hopefully we can get everything in there in one shot. Bless you. Okay? Any questions? LAO. Okay, it's just the opposite. So 30 to 45 degrees obliquity on the other side. Center to the iliac crest. And slightly on the upside, on the right side of the spine, on the mid-sagittal plane. Okay, 30 to 35 degrees obliquity. So if this is an RAO,
Alio.
if this is an LAO, what is it similar to as far as the anatomical shape and positioning?
RPO.
Okay, RPO. Now, that's for single contrast study. Is it going to look the same whether you're doing an RAO versus an LPO in a double contrast study?
Yeah.
Yeah, because of the anatomy. Remember, this is back and this is front. So whether you're doing an RAO versus LPO, contrasts in air are going to settle in different areas. Single contrast study, it doesn't make a difference because it's single contrast. Okay, you're just dealing with barium. If it's double contrast study, the barium in air will settle in different places, from an RAO to an LPO or an LAO to an RPO. So again, this criteria that you have here in your book is based on single contrast studies. So, same criteria as an RPO as this LAO. The left colic flexure now is going to, left colic flexure and the descending colon are going to be open. So now it's the opposite flexures that are open. And the entire large intestine should be demonstrated. Again, same applies if we're looking at the flexure, center a little bit higher. If we're looking at the lower rectal sigmoid area, center a little bit lower. Okay, but for the most part, we can get everything on one 14 by 17 image receptor. Okay? And then here's your LPO and RPO. Okay? Same thing, 30 to 45 degree rotation. Center at the crest. And then 1 inch above the mid-sagittal plane on the upside. 1 inch from the mid-sagittal plane on the upside. 1 inch from the mid-sagittal plane on the upside and the iliac crest. Okay. Any questions here, guys? All right. So again, we covered the positions and the opening of the flexures on the other slide, so I'm just going to keep on going. Are you guys okay with that?
Mm-hmm.
This is already covered. We already talked about this. Okay. Lateral or ventral decubitus. Lateral or ventral decubitus of the rectum. Okay. There is a difference. If they are on their side, okay, and it doesn't matter again if they're laying on their left side or their right side, they're laying on their side with a horizontal beam. This shot down here is specific for the rectum. Now, if it's recumbent with a, vertical beam, this is single contrast study. Okay, if they're on their side with a vertical beam, this is for a single contrast study. If they are on their belly, okay, this is a decubitus now, right? Because they're recumbent, they are ventral, they're on their front side, but the horizontal beam, this is for double contrast study. Okay, so lateral recumbent for single, lateral decubitus with the horizontal beam for double contrast. In either case, put the patient in a true lateral position in relation to the image receptor. So a true lateral position in relation to the image receptor. Central ray is going to be at the level of the as is and the mid-axillary plane. Now, a simple way of doing this, and this works greater than 80% of the time, is you're using your smaller receptor, and you're putting the edge of the bottom edge of your image receptor right below the butt crease. You just line it up right below the butt crease. You guys see that? Right at the butt crease. Okay.
That's for both of them?
For both of them. Yeah. All right. So here again is a single contrast study of the rectum. So if this is a single contrast study, are they in a ventral decubitus or in the left? Are they in a lateral recumbent?
Lateral.
Lateral recumbent. Okay. So the rectal sigmoid area is demonstrated with no rotation using optical exposure factors. Now, when you guys are doing this, okay, see this cross table. What should you be using here? In
Grid.
addition with your image receptor, a
Grid.
grid. Why are we using a grid?
Because of the thickness of the body part.
Because it's thick, it's going to cause a lot of scatter radiation, so you want to use a grid. Okay? Here the grid's already built in into the table. Here we gotta put one on. Okay?
Are we increasing KV?
KV's going to still be about 110, 125.
But we would increase the mass though, right?
The mass is going to be for barium studies, again, depending on your facility, is anywhere between 16 to 25 mass.
But with the grid, we would bump up the mass, wouldn't we?
No, the grid's it's going to stay the same. Because your 110, this right here, is already in the bucket.
No, I'm talking about mass. The
Mass?
Yeah. If we're using a grid, we'd bump up mass, wouldn't we?
It's going to stay...
Isn't that the Bucky factor?
No, the technique that I give you is for a grid.
Oh, okay.
Yeah.
Oh, okay.
Yeah. So over here, then your mass over here on the table would be somewhere like between like 8 to 12.
It'd be the same for...
Yeah. So if you're using the grid, then you're going to bump it up just a little bit on the grid.